Hi, everyone. I am Oliver Hall. I am the Trans Health Director with Kentucky Health Justice Network. And here talking to y'all today about hormone replacement therapy, we have Dr. Folsom, who is a pediatric and adult endocrinologist with Norton Children's and Norton Healthcare and U of L Pediatrics. So I'm going to go ahead and turn off my webcam and let Dr. Folsom take over.
Well, thank you so much, Oliver, for inviting me to come and talk with the group tonight, and thank you to everybody who's attending. I am going to share my screen, and if you cannot see it, let me know if there is something we need to do differently. Actually, Oliver, can you tell me if you can see my screen?
Yep, it's good.
Okay, and is the go to meeting tab in the way, or is that missing as well?
Yeah, no, it's not showing up. It looks perfect.
All right, awesome. So before we get started, I wanted to talk just a little bit about why I do this, why I provide gender affirming hormone therapy to transgender people. And it started back when I very first started my fellowship training. I did not know that gender affirming hormone therapy and transgender care was part of endocrinology. I chose to be an endocrinologist because I like hormones and I like the endocrine system and I love the intricacies of the feedback loops between the two. But then during my first month of fellowship, I met a transgender lady, and being part of her journey, being part of her ability to transition from a body that she did not identify with, a body that was foreign to her, and helping her to become the person that she'd always been on the inside, but to help other people see that was a transforming experience. And I realized that I needed to have that as part of my life and as part of what I was able to do. And so I, during my fellowship training and then afterwards, made sure to include information and education and training about this process, this part of endocrinology, so that I would be able to do this for people and to really be a part of their journey. So I'm delighted to be able to talk with you all this evening about what I do, and then I have prepared a presentation, but we'll also hopefully have plenty of time at the end for questions and to really kind of narrow things down and dive deep into the specifics. So before we get too far into this, I do need to let you know a few things. The first of which is that prescribing hormone therapy for a medical transition in transgender individuals is off-label. It is not approved by the FDA for this purpose. The medicines that we use are approved by the FDA for other purposes, for other medical conditions, but not specifically for transgender care. However, I do this because I am 100% convinced that it is imperative for transgender individuals to be able to live in the bodies that are in line with who they are on the inside. And so I think as long as we know the risks as well as the benefits, this is something that's imperative for the well-being of the patients that I care for. What I hope that we'll be able to do during our time together this evening is first just review gender-affirming terminology. I know that a lot of the people who have tuned in tonight are already intimately aware of these terms, but there may be some people who are just learning about what is a transgender person, what terminology do we use, what terminology should we not use. So we'll talk a little bit about that. And then we'll understand the science behind hormone therapy. Why do we do this? Why does it work? What changes are because of the hormones? And then we'll talk a little bit about options for transition in transgender care, both hormonal and non-hormonal. We'll talk about goals of treatment. How do we decide what medications to use, what surgical procedures to use, and if we want to use a medical procedure or medication at all. And then we'll spend a little bit of time talking about resources and opportunities for advocacy for the LGBT community. Talking about terminology. First, let's talk about sex. The definition of the word. We can talk about that in a different talk. Chromosomes, body parts, biology, the anatomy, what the body looks like, and what's the biochemical makeup of the body refers to sex. sex is what we think of as when a baby is born, the doctor looks at the baby and says, your baby is a boy, girl, this is sex, this is what it looks like. Gender is socially constructed roles, behaviors, and activities. So in the 1940s, the typical female gender person, maybe she stayed at home, maybe she wore a dress and an apron, maybe she did the cooking and the cleaning, and maybe the man went to work. But in 2021, maybe the woman goes to work and maybe the man stays home, or maybe it's an LGBT couple and maybe there's two women in the home and maybe both of them go to work. So gender is a social construct. It has nothing to do with who the person is on the inside. Gender identity, in contrast, is an individual's perception of his or her or their gender. This is who we are on the inside. Sometimes it does not match what our bodies look like. Our gender and our sex may not match, but gender identity is all about the individual. And then totally different from any of these things we've talked about before is sexual orientation. And this is an external thing. This is our attraction. Who are we sexually or romantically or psychologically attracted to? I had this beautiful patient who told me one time, my gender identity is who I go to bed as, and my sexual orientation is who I go to bed with. So sexual orientation is the people that we are attracted to. Another way that I think is really helpful to explain this, especially to people who aren't really familiar with the terminology, is using a visual. And this is one such tool called the genderbread person. And you can see that the genderbread person has a brain, they have a heart, they have a body, and then they have a private part anatomy. And we use this to say, your sex is what your private parts are. Your sex is your chromosomes, your biology, what were you born with. Your identity, that brain, is who we are on the inside. Our heart is who we're attracted to. That's our sexual orientation. And then our body are what we use to express our gender identity. So today I'm wearing pants. Am I expressing a more masculine aspect of my gender identity? Maybe I'll wear a dress tomorrow and that's a more feminine expression. But expression is how we present ourselves in the world. And sometimes that's in line with our identity and sometimes it's not. So this is a nice tool to use to kind of bring people along with us. When we talk about a transgender person, this is an individual whose gender identity and sex assigned at birth are different. They're not the same. In contrast to a cisgender person, who's a person whose gender identity is consistent with the sex they were assigned at birth. When I was born, the doctors told my mom I was a girl and I identify as a woman, so I'm a cisgender person. But if I had been born and the doctor had said this is a girl and I said, no, I'm a boy, then I would be a transgender person. And then there's this other kind of a group of words used to describe someone who is neither male nor female, someone who identifies as non-binary, gender fluid, gender queer, sometimes called gender non-conforming or gender incongruent, agender, and a term that I really love that I didn't include here because I didn't have space, but gender expansive. And this is someone who just doesn't identify as one or the other, but maybe has aspects of both or neither. When we talk about gender dysphoria, now this is really important because you can be transgender and this is fine. It's fine that your body and your identity don't match, and that's a lot of transgender individuals are that way. But if the body and the mind discrepancy causes distress, this is what's known as gender dysphoria, and that's when we need to do something about it to relieve that distress. And one of the things we can do as people, as humans, is to be gender affirming, using terminology and doing behaviors and helping with interventions that can affirm a person's gender identity, that help them know that we love them because of who they are, not because of what their body looks like. Some examples of these are using a person's affirmed name when we speak to them and about them, using the correct pronouns when we talk to someone and about someone, using the right body parts. I would never refer to a man's chest as his breasts, and so why would I refer to a transgender man as having breasts? You want to use the right terminology. And then using sex hormones to assist with medical transition if that's something that's part of a person's journey. So why do we do this? Why do we care? And the reason we care is that this is a huge deal. One big piece is that, you know, we don't know what causes us to have our gender identities. We know that about just over 0.5% of US adults, about 1.4 million, self-identify as transgender. And as I mentioned before, not all transgender individuals meet the criteria for gender dysphoria. Most people aren't upset about this fact, or at least to the point where they wish to have medical care. But in order to have medical care, currently most insurance companies require a diagnosis of gender dysphoria before they will approve any sort of medical gender affirming treatment. Now, this may change in the future. Right now, we use the ICD-10 medical coding logistics, but when we upgrade to ICD-11, they're going to replace gender dysphoria with gender incongruence, meaning you don't necessarily have to have that dysphoria in order to be approved for hormone therapy. But for right now, you do. So transgender people need the healthcare system, which is a problem sometimes because there are huge barriers to getting healthcare for everyone in the US, not just transgender individuals. But specifically for transgender individuals, 20%, 1 in 5, have had a negative prior experience with healthcare, specifically being denied care by a physician because they are transgender. That's not okay. There's also real and perceived hostility in healthcare settings. They're nervous, they're afraid that their doctor is going to do something or say something, or that they're going to be treated in a way that reinforces this dysphoria. There's also a real and perceived lack of provider knowledge. You don't want to have to teach your doctor how to care for you. You want them to already know. And then there's always the concern about ID and identity mismatch. When you check into the office and you hand over your insurance card, the name is different than your name, and having to explain that can be really awkward and uncomfortable. And then the lack of insurance, the lack of hormone coverage is part of health insurance. And that means a lot of people will buy their medications from places that maybe aren't as safe. Maybe they're buying them on the internet or from a friend or using someone else's, and that can introduce health concerns. And then we know that people in the LGBT community are disproportionately affected by psychosocial stressors. Anyone who's part of a minority group, whether that's gender or sex or ethnicity or racial groups, we do tend to have increased stressors, and that can also result in healthcare barriers. A study done back in 2011 asked 6,000 transgender people about their experiences with healthcare, and almost 30% said that they delayed going to see a doctor because they had been discriminated against in the past. And 19% of those who did, almost 20%, were denied care when they did go to seek care. And 50% of these people surveyed reported that they had to teach their providers about their own healthcare. And again, when I go to the doctor, it's because I want advice and I want to be cared for by an expert. And when you don't feel like your doctor is an expert, you may not wish to go and see them. So let's say that we do have gender dysphoria. Let's say that we do, psych ourselves up to going to the doctor. What does this look like? What is transition? What is that process of becoming on the outside who we are on the inside? And the word transition really is, it describes this process, the process from living and being perceived as the gender that you were assigned at birth, to living and being perceived as the gender with which a person identifies. So really moving into the body that you should always have had at the beginning. And it's really important to know that transition doesn't always include medical care, such as surgery or hormones. Transition happens on so many different levels. Hormonally, sure, but also linguistically. How do you refer to yourself? What words do we use? What words are used to describe you? A psychological level, intellectually, spiritually, potentially surgically, but socially, emotionally, and then legally as well. So lots of different levels of transition. But when we're thinking about transition in a medical setting, what I think about as a physician, as a healthcare provider, is I really want to make sure that my patients are cared for from a mental health standpoint and from a physical health standpoint, as well as from a medical standpoint. I don't just want to prescribe hormones and send people on their way. I want to make sure that the whole person is being cared for. As far as mental health, I think this is something so important, and I am a provider who asks my patients to be seen by a mental health professional before starting hormone therapy, because I would much rather have a mental health person that you know that you can call and never have to need them than to develop a mental health issue after starting hormone therapy and not have anywhere to go to discuss it. So I think having a mental health person on board at the beginning is really important. Some of the things that come up can be dissatisfaction with the pace of physical changes. When you start hormone therapy, this is something that you've been thinking about for a really long time. And once you do it, you want the changes to happen right away. And sometimes it takes a long time. So having a mental health person to help process that can be very helpful. Also, body image concerns. Maybe the body that you get is not in line with the body you had pictured, and having somebody to help process that can be very important. And then conflict with friends, family, and coworkers as you begin that transition, as they begin to see your body change. Dealing with those issues that come up can be helpful. And then how to go about the process of going into gender-specific public places. How and when do you decide to use a different bathroom or a different locker room or go to a different part of the gym? All these things can be really good to talk about with a mental health professional. So if we do decide that medical transition is the thing we want to do, why hormones? Why an endocrinologist? And this is a picture of the hypothalamic pituitary gonadal axis. You can see at the very top, the brain controls our hormone productions. The brain makes a hormone called gonadotropin releasing hormone, which stimulates the pituitary gland lower in the brain to produce LH and FSH, which stimulate either testes or ovaries, whichever are present, to make testosterone, or estrogen and progesterone. And that really starts the puberty process and then continues to provide sex hormones throughout our life. If you are making a sex hormone that is not in line with your gender identity, then we need to interrupt this process and make sure that you're provided with the appropriate sex hormone. And that's part of what I do as an endocrinologist. When I meet with patients for the first time, we have a conversation about what our goals are. What are they hoping to see with hormone therapy, and what can we achieve? And really, for medical goals, the first is to reduce the sex hormone that the person is making and then replace it with the proper sex hormone, with the one that really goes along with their gender identity. And those are really the two goals, the things that we look for. So where do we start? How do we know how to do this? Why do I get to do this for my patients? And what I use is two sets of guidelines. One is published by the Endocrine Society and the other is published by WPATH, the World Professional Association for Transgender Health. And these are two very well researched, very well put together sets of guidelines summarizing all the things we know about hormone therapy for transgender individuals. Now, I must tell you that all the things that we know is not a whole lot. There's so much more that we don't know. And so I start with these guidelines, but then we create a custom plan for each person so that they're really able to maximize their treatment plan. I wanted to talk just briefly about puberty blocking treatment, both because this is something that I will use in my younger patients in my pediatric clinic, and also because it's been in the news lately, specifically with the ruling with Congress in Arkansas. Puberty blockers push the pause button on puberty. They don't let puberty progress any further. They also don't turn the clock backwards. They just pause it and let that individual who's just starting out down that road of becoming an adult really have the time to explore their gender identity and what their goals are for the future. We only begin these when there are signs of puberty, because if there's nothing to block, there's no medicine needed. And we often find in kids and in teenagers that once they're able to start these puberty blockers, their behavioral problems and their mental health improves, because you don't have that worry that your body is running away from you and you can't control it. Once puberty is complete, puberty blockers are not as helpful because, again, you've finished that piece of your growth into adulthood, but sometimes we do use them in certain situations. The way that they work is just by pausing that GnRH from the hypothalamus. And so because that's paused, sometimes you can have some complications. We often will give this as an injection, an intramuscular injection, so there is a risk of infection. There's also decreased risk of bone mineralization. And if we only use these for a few years, then it's not as big of a deal. But if someone were on these for a very long time, there would be the risk of osteoporosis in adulthood. Sometimes kids can have higher blood pressure, they can have hot flashes because there are no puberty hormones being produced. And in people who have ovaries, they can have irregular periods as well. They can also have a change in fat mass, and so decreased fat distribution is something that we find. Moving on to adults. So there are some criteria for using gender-affirming hormone therapy in adults, and the first is that they have to have gender dysphoria or gender incongruence that's been well documented and that has been going on for a long time. So if someone wakes up one morning and all of a sudden identifies as the opposite gender, whereas the day before they didn't, it might be worthwhile to process that a little bit more and really decide if hormone therapy is the right thing. People also need to have the ability to make a fully informed decision and to be able to consent for treatment. We have to be able to talk about the risks as well as the benefits and make sure that those are understood. And then if the person has any mental health concerns, they don't have to be gone, but they need to be addressed and they need to be treated at the same time. So when we talk about gender-affirming hormone therapy, we talk about the sex hormone that we're using to affirm the person's gender identity. So for transgender ladies, we typically use estrogen in the form of 17-beta estradiol. And this can be given either orally as a pill, transdermally as a patch, or given as an injection, either given into the muscle or under the skin. We also often use anti-androgen medications or testosterone blocking medicines because they can work together with estrogen, so you need lower doses of the estrogen, which may potentially decrease the side effects. Spironolactone is the first one that we most often use in the US because it has the least risk for side effects. But we also will use bicalutamide, which is a different type of androgen blocker. In Europe, they will use a medication called cyproterone, which is a progesterone medicine, but it's not available or approved in the US, and so we don't use that here. When we think about the expected physical changes in transgender ladies, with estrogen, we'll have a redistribution of body fat into a more feminine manner, decrease in muscle mass and strength, softening of the skin, change in sexual desire. I will say that some people find an increase in their sex drive on estrogen, and some people find a decrease. Breast growth is obviously something that we see, decreased testicular volume, sperm production, a decrease in body hair, and an increase in scalp hair. And as you can see, these changes take a little while to start and even longer to really see the maximum effects. If we use breast growth as an example, you can see that it can take up to 3 years to really see the maximum effect. And so this is something that does take a lot of time and requires some patience. When we think about risks with estrogen, the biggest risk is that of blood clots or thromboembolic disease. And I always ask my patients if they've ever had a blood clot, if they have a family history, and we talk about this at pretty much every visit, knowing that it is a risk. Not that you shouldn't choose to take hormone therapy, but knowing that every good thing has some downsides. There's also a moderate risk of prolactinoma or a pituitary gland tumor that produces prolactin. Risk of breast cancer, whether you grew breasts at 16, 26, or 66, every woman has a risk of breast cancer. Coronary artery disease, gallbladder disease, and high triglycerides can all happen with estrogen therapy as well. So knowing this is important as we embark on the journey together. And when we think about masculinizing treatment or transgender men, testosterone is really the mainstay of therapy. And similarly to estrogen, testosterone comes either as an injection given into the muscle or under the skin, or on top of the skin, transdermally in the form of a gel or a patch. We also sometimes will use progestins in transgender men, and the reason we use these is to stop periods. It can take a while for testosterone levels to reach levels where the periods go away on their own. And so sometimes we'll use medications such as norethindrone, which is a daily oral pill, or medroxyprogesterone, also known as Depo-Provera, which is an injection given every 3 months to stop periods while we're working up on the testosterone dose. When we think about effects of testosterone, think about early teenage boy puberty. So you first get oily skin and pimples and sweatier and stinkier sweat, and then the good things happen. So increased muscle mass, increased strength, fat redistribution into a more masculine physique. Periods often will go away, and people do experience bottom growth. Sometimes there's some vaginal atrophy and dryness, which can be surprising, and then deepening of the voice. And again, when we look at the time frame for when to see the maximum effects, there are some of these that really don't reach the maximum effect until 5 years of therapy. So again, it is a process and it takes a while to really see the effects. And there are risks with testosterone as well. Any good thing has some downsides. And the biggest risk is erythrocytosis, or elevated red blood cell count. This is part of the reason that athletes who are a little bit less ethical will sometimes use testosterone to increase their red blood cell count so they can perform better. But this is also something that can increase our risk for liver dysfunction and inflammation, coronary artery disease, stroke, and high blood pressure. So counseling about these possibilities can be really important as we begin starting therapy. And something that I wanted to touch on briefly is the fertility effects of hormone treatment. Even 10 years ago, we were telling our transgender patients that once you start cross-sex hormone therapy, there's no chance of having biological children. And that is not true. Now, we do know that people who have testes, when they take estrogen, it does suppress their ability to produce sperm. And we don't really know if you can begin to make sperm again after you've been on estrogen for a long time. But we've seen in real life that transgender ladies have been able to come off testosterone and have been able to have those sperm extracted and be able to have biological children. So we don't know that everyone can, but we know that it's happened. And for people with ovaries, we don't know about the long-term effect of testosterone on the ovaries, but we do know that many transgender men have become pregnant on testosterone therapy, or maybe they've taken a break and they've become pregnant, or they've had eggs harvested and fertilized. So it is possible to have biological children in whatever way you wish to. It doesn't mean it's a guarantee, but it also doesn't mean that you're infertile. So what if you know that you want to have biological children? What if you go into this knowing? If a person has testicles, then sperm banking is absolutely an option, but it is expensive. The process of extracting that sperm, analyzing it, processing it, and freezing it is about $350 to $460. But then you've got to store it, you've got to keep it, and that's about $240 to $480 per year. So you can pay for it, but it is something that needs to be paid for. And for people who have ovaries, let's say that you want to keep those eggs just in case you might want to use them in the future. You can cryopreserve your eggs, which are oocytes, a fertilized egg, an embryo, or the ovarian tissue by itself. And this is also really expensive. So it costs about $10,000 to prepare that tissue, to harvest those eggs and to freeze them. And then you have to store them, between $300 and $500 per year, depending on the facility that you use. So that's $10,000 plus $300 to $500 per year. But then you get to the point in your life where you're ready to use that genetic material. It costs about $5,000 to prepare, to thaw, and to implant those eggs. So it's possible, but it is expensive. And right now, most insurance companies do not cover this process. There are some larger companies who do, but in general, it's something that people have to plan for and save up for. So it's not perfect, but it's possible. So when we think about hormone therapy, goals, when a patient comes to see me in my office, what should they expect? Well, lots and lots of talking. I tend to want to make sure that they know everything about what the risks are as well as the benefits. And so we will have a pretty long conversation about their journey, what they've experienced, what their gender identity is, what their goals are for treatment. Also expect to be examined. I listen to hearts, I listen to lungs, and depending on what we talk about during the visit, if there are any worries or concerns about puberty or sexual function, we may do a puberty exam to stage where the person is in the process. And then expect to have lab work done. I have to test baseline levels of the hormones to see where they are before we start therapy so we can monitor where they're going. And I will often look at blood counts, liver and kidney function, and cholesterol because all of these can be affected once we start hormone therapy. And in my office, not in everyone's office, but in my office, I do ask patients to have that mental health evaluation because, as I mentioned, I want you to have a good person in your corner, hoping you'll never need to use them, but I want you to have that safety net just in case. And then expect a little bit of waiting. And this is the most frustrating because there are so many barriers to starting hormone therapy, which I hate, but I also want to make sure that we do things safely so that once we start, we don't have to stop. We don't have to back off later. And what not to expect. What should you not expect? And what should you not experience when you go to see a healthcare provider? Well, in my office, most people do not begin medical treatment the same day because we have to do those labs and we have to have that mental health evaluation. And don't expect immediate changes. You're not going to wake up the next day after your first testosterone shot with a full beard. You're not going to wake up the next day after your first dose of estrogen with beautiful adult breasts. Puberty takes time and this process takes time. But also, don't expect to be treated any differently than any other human being because regardless of what our bodies look like, regardless of who we are on the inside, regardless of our gender identity, we are all humans, and being respectful is the most important thing and something that everyone should expect from their healthcare team. Medication affordability is something that does come up a lot because hormones can be expensive. Right now in 2021, most commercial and government insurance plans do cover medical hormone therapy. If you're not sure, you can check with the insurance company or just ask the pharmacy to run the prescription through the insurance to find out how much it'll cost. Sometimes a prior authorization from your doctor is needed, and if that's the case, you just reach out and we can fill that out in our office if you're one of our patients. Another really nice option is goodrx.com, which you're able to buy medications without insurance using this program that is free that you can sign up for online. And it will not only tell you how much you should expect to pay, but it will list pharmacies in the order from least to most expensive so you can get the best deal on your medicines if they're not covered by insurance. And then there are also certain manufacturers' patient assistance programs. So the company who makes the medicine wants people to use it. And so oftentimes they will give you a discount if there is one available. And then finally, large pharmacies such as those at Costco, Kroger, Meijer, Sam's Club, Walmart, et cetera, will have discount medication programs. And so if your insurance is not paying for it or it's too expensive, looking into those programs can be a good option. If you are someone in the Kentucky and area, these are some local resources that can be really helpful to provide information, education, financial assistance as you move forward through your gender affirming journey. The Kentucky chapter of the ACLU, our Fairness Campaign, the sponsors of tonight's event, the Kentucky Health Justice Network, Trans Health Advocacy Group, Louisville Pride, Queer Kentucky, and Trans Kentucky. These are all really good local resources. And if you're not local, then you can also use these national resources. The Human Rights Campaign, OutCare Health gives a nice summary of a variety of gender-affirming providers, Trans Lifeline, Transgender Pulse, Transgender Roadmap, and Trans Women International. These are all national groups that really work to affirm the LGBT community. So I know that was a lot, and I am so delighted that you were able to join for this part of the session. I am going to attempt to stop sharing my screen, and I think Oliver was going to tune back in, and then we can have a discussion, we can talk about questions, and I'd love to hear some of the experiences that you all have as well.
Should be coming back. Okay. Hey, y'all. So it looks like we do have one question there so far. They say, hello, as someone with PCOS, how does that affect my hormones, especially if I choose to get on T? And what effects might that have as I age?
That is a really, really good question. So PCOS is polycystic ovarian syndrome, and that is an endocrine condition that a lot of biological females experience, where there's an imbalance between the amount of testosterone and estrogen that the ovaries make. And so you kind of have higher testosterone levels than a woman who doesn't have PCOS. And that can cause some of those masculinizing changes that you would get with testosterone. So some folks with PCOS will have irregular periods. Sometimes they'll have dark hair growth on parts of their body that you wouldn't typically expect. Sometimes acne, sometimes oily skin, cysts on the ovaries are things that we see. And if you have PCOS and you want to start hormone therapy, okay, this is one of the things we don't know. We do not know if individuals with PCOS on testosterone have higher risks with testosterone treatment than those who don't. We know that the risks with testosterone, the things we talked about, the heart disease, the stroke, the high blood pressure, are going to be there. We also know that when you have PCOS, you are at slightly higher risk for type 2 diabetes and high blood pressure, but we don't know that those risks will be higher on T. It is important, if you have PCOS and you want to start testosterone, to let your prescriber know about that, because they may want to watch a little bit more closely. They may want to keep a slightly closer eye on your cholesterol numbers. They might want to watch blood pressure. You might want to start treatment for high blood pressure or high cholesterol sooner if you develop those things, but it's certainly not a deal breaker for starting T.
Sweet. Someone also just says, hi, Dr. Folsom, thank you for this very important and illuminating presentation. And then we have another question. Especially for non-binary people who are interested in medical transition, are there HRT options that are not as quickly feminizing / masculinizing?
Oh gosh, that's such a great question. So we know that you have two options for sex hormones. There is estrogen made by ovaries and testosterone made by testicles. And when you're a non-binary person, you don't really want to look like a woman or to look like a man. You want to maybe be somewhere in the middle or be neither, be more of an androgynous appearance. And the problem is that sex hormones are binary. You can have one or the other. When you are thinking about hormone therapy, though, the biggest thing that I think about in regards to developing a regimen for someone who is non-binary is, what are the things that we need to prevent from a medical standpoint? And really not the whole reason, but one of the reasons we have sex hormones is to protect our bones. We know that people who lose their sex hormones early, a person who has testicles who, heaven forbid, had torsion of both, they twisted, they died, you had to have them removed. That would be terrible. But they wouldn't have testosterone anymore, and they would be at a higher risk for osteoporosis. For a lady who goes through premature menopause, she's at a higher risk for osteoporosis. And so we know sex hormones play a really important part in bone mineral accrual or development. So when I'm thinking about that with a non-binary person, I will recommend or prescribe low doses of whatever sex hormone is the least offensive. So if you were born with ovaries and feminization is more scary than a little bit of masculinization, then we'll develop a regimen that involves a very low dose of testosterone, maybe not even high enough to cause a lot of physical changes. Maybe you'll just get sweaty, or maybe you'll get, some oily skin, or maybe just a little mustache, just a tiny bit of masculinization, but enough testosterone to protect the bones. And similarly, if it's less scary to be a little bit more feminine, then we might prescribe just a very low dose of estrogen, enough to protect the bones, but hopefully not as much that you're going to see that full expression of that sex hormone.
Awesome. That makes a lot of sense. That is a really helpful answer. So we have another question. What about autoimmune diseases in HRT? Concurrent treatment with steroids or arthritis medication and Ehlers-Danlos?
That is such a good question. And again, we don't know. We don't have enough data looking at people who have those same conditions to be able to give a blanket statement. I will say that neither testosterone nor estrogen is known to suppress the immune system. Otherwise, all of us who have gonads would have a suppressed immune system. I make estrogen, my immune system would be suppressed. For people who make testosterone, that would be the case as well. And so I don't think that having an immune condition or a connective tissue syndrome like Ehlers-Danlos would be a contraindication. I do have some patients who have some other autoimmune conditions like autoimmune thyroid disease or type 1 diabetes. And in those situations, I just manage everything together. I manage the thyroid, I manage the diabetes, I manage the hormone therapy all together. So we think about each thing when we're treating the other, but we do it all together.
Another person says, awesome presentation. Thank you for being awesome, or thanks for being awesome.
Aw, thank you for being awesome.
Aw. And then another person asked, is there a role for, oh, I don't know how to say this. You might have to look at the question, but I'll try. Is there any role for using Tamoxifen if you are a biological male who is non-binary but doesn't desire breast development?
Oh, that's a good question. That has not been studied. So tamoxifen, what it is it's an aromatase inhibitor, and it's supposed to decrease estrogen production. Okay, hold on. Now I need to look at the question because I got all excited about this. Let's see. Uh-oh, I don't know. Can you read it again, Oliver? I can't scroll up.
Is there any role for using the word, if you're a biological male who is non-binary but doesn't desire breast development?
Ooh, gotcha. Okay. So it hasn't been studied in that particular situation, but it has been studied in kids for other reasons and adults for other reasons, and it doesn't seem to work very well because one of the things that it does is it might increase the hormone that comes before. So let's say that you're taking it, and then the hormone that you're blocking goes up and up and up. So you might even see more effects of that hormone. So it hasn't been studied, but physiologically, I wouldn't recommend it. If you're a non-binary biological male, though, thinking about a surgical intervention. So if you don't want hormone therapy, but you also don't want that chest growth, there is the possibility of just having that surgically removed without starting hormone therapy. There's a slight kind of possibility that you may get a little bit of regrowth if you're still producing estrogen, but probably not to the degree that you started with.
Got another question here. How do you currently handle situations where a person's insurance does not have coverage for or has special exclusion for gender divergent diagnoses? Are you able to help get insurance coverage for HRT at all? Or are they recommended to pay or get different insurance?
So if the person's insurance has an exception for gender affirming hormone therapy, let's say that you have insurance plan and specifically in the plan, it says, we will not pay for cross-sex hormone therapy, then it's really difficult to work around that. But if it just says, we don't want to pay for it, or it's, one of the medicines that's not approved, we can write an appeal to the insurance company. We can do a prior authorization. And if they still say no, then changing to a different insurance plan is always an option, one that will cover it, or using one of those pharmacy benefit programs like GoodRx can make it affordable. Testosterone, last time I checked in Louisville, was between $37 and $50 for a vial with GoodRx without insurance coverage, so it still can be affordable. And the oral estrogen pills are pretty affordable too, even without insurance.
I'll also add in there, Oh, sorry.
Oh, no, go ahead, Oliver.
I was just going to add in there that our organization KHJN does provide financial assistance for copays for hormone replacement therapy. So, especially if you're having trouble getting insurance coverage, we also help people write appeals, especially internal appeals to their insurance company, if that is something that you need help with.
Oh, yes, call Oliver. Call him. Call them.
Yes, yes. Got another question. Hello, Dr. Folsom, you're incredible. If you know of a child that is around the age of 10 who is having extreme behavioral issues and has told their teacher that they are transgender, but their parents are 100% against this, what do you recommend in situations like this, especially since the child has no independence or choice in the matter at this age?
That is a heartbreaking situation. So if a child tells a trusted adult that their gender identity is different from their sex assigned at birth, and their parents, the people who have been put into this world to love them and care for them, are against it, then I mean that's a huge deal. What I would suggest is if the teacher feels comfortable asking the child if they, and it sounds like the parents know because the parents are against it. So what might be a good first step is to get the child and the parents to see a gender knowledgeable therapist. So to start with just some family therapy and have those discussions and be able to bring the parents to a place where they at least understand what their child is struggling with, and then be able to work together as a family towards some sort of a solution. The thing about being 10 is that a lot of times you're just kind of starting puberty. And so there is some time to process those gender identity questions and help bring the parents along. But I do think that especially if you're in a situation where the kid feels one way, the parents feel another way, doing that family therapy to find somewhere to meet, to find some common ground is going to be the first step. Because you're exactly right. The child's not going to get the care they need unless the parents are at least willing to bring them to a provider or a place where they can get a little bit of assistance.
Really, that's a really good answer to a really hard question. When I read that, I was like, oof, that's extremely tough. Okay, we got another question here. How does hormonal birth control work with T, both in regards to pregnancy risk, but also when used for period regulation and acne?
Yeah, great question. So if you're a transgender man or a person on testosterone, there should be no estrogen in your system, or very, very little. Testosterone is metabolized to estrogen, so there will be a little bit of production, but you don't want to give estrogen and testosterone at the same time because you don't want any feminizing effects. So instead of using kind of a typical hormonal birth control, like an oral contraceptive or a patch or something like that, what I will typically recommend is a progesterone-only medication like norethindrone, using Depo-Provera injections every 3 months for birth control or contraceptive purposes. Or a lot of trans guys will get an IUD, which is the intrauterine device, which either just releases local hormones that don't cause any feminization, or the copper one, which doesn't release any hormones at all. And that's a really nice way to make sure that you're not becoming pregnant accidentally, that the periods stop, but you're also not taking an estrogen, which could cause, potentially some feminizing changes or work against the testosterone.
All right, next question. How do you talk to parents about HRT who may be concerned about their child or adolescent's decision-making capacity or commitment, not necessarily understanding that gender identity is established at school age? Any best resource to provide for parents interested in learning?
Yeah, that's a great question. So I think parents who are interested in learning are the best parents because it means that they're open to changing their viewpoints on things. There is a book called This Is How It Always Is, and it's a fictional book, but it's by a lady who has a transgender child, and it's about this family who has a transgender daughter. And it's about the process of trying to really understand and work through that. So that's a good book for them to read. But I think, we we know who we are. You know, we know that we are humans. We know our gender identity. We know how many arms and legs we have. We know who we are. And in kids, I think parents sometimes do them a disservice a little bit of the time and say, you know, you don't know who you are. You're going to change your mind when you grow up. I knew that I was a lady from the time that I can remember, and I never questioned that. And even if kids kind of come out or recognize their gender identity a little bit later, I think having a good therapist to work with the kid to make sure that they're thinking about things the right way, that they've considered all the different options, that if they do have depression and anxiety, not that those are going to affect gender identity, but they can affect the way that they look at the world and look at themselves, that those are being treated. And really, I think just making sure the parents know that loving their child and supporting their child is the most important thing. If the parent has their child's best interests at heart, it doesn't matter if the child changes their mind later, right? You want to support your child where they are now, use affirming terminology, use their name, use their pronouns, and help them to really work with a therapist so that those issues can be talked about. And then parents have to consent for therapy now, and so making sure you bring the parents along in those discussions. But I mean, love your child first and worry about their gender second.
Yes, absolutely. Okay. Hi, and thank you for your time tonight. I've been on HRT for 4 years. MTF, I am still building fat around my midsection, like a beer gut. Should I be concerned? My doctor has dismissed it, and my current doctor has dismissed it. Labs look okay, but I've put on quite a few extra inches over the last year, even after diet and exercise changes. I'm feeling more and more uncomfortable about it.
Ooh, that is a tricky situation. I think not to discount this, but a lot of people have had some similar experiences during the last year with COVID and takeout and all of this. Not that this is what you're experiencing. With estrogen therapy, we do find that fat redistribution, but we do often kind of find that we gain weight as we get older as well. And estrogen, especially in someone who started out with testosterone, does tend to make it a little bit easier to gain weight. There are a few endocrine specific conditions that we think about with weight gain. Things like excess cortisol is really the biggest thing that kind of coincides with weight gain. And so thinking about that, having your doctor think about that would be a good idea. Exercise, nutrition, healthy eating are all really hard things to do. But I think it may be the estrogen, it may be the COVID, it may be just getting older. But I think thinking about other medical things and asking your doctor to look into those, or asking for a referral to an endocrinologist or even a cardiologist, something like that would certainly be a reasonable option.
Next person says, thank you for the presentation. My therapist has said it would not take long with informed consent to start HRT after the first appointment. Is that unusual? And I love the mug, Oliver. Thank you.
Yeah, you got 2 votes for your mug. I love this.
Yeah.
Yeah, so I think really the 2 things that I wait on before I start is that documentation from your mental health provider saying that you are mentally competent to make an informed decision, and then the lab test to come back. Usually the labs are back within a week. So if a person comes to the appointment with the letter, or the therapist has sent it ahead of time, you can start, within usually a week after seeing me, at least for the first time. There are some other providers who will start sooner than that. Some people don't get labs beforehand, and it really depends on kind of what sort of hormone care you're looking for. If you want to see an endocrinologist, or primary care doctors also prescribe hormone therapy, Planned Parenthood. So for me in my office, if you've got all the pieces together, it can happen pretty soon.
The next person says, what can transmasculine people do to mitigate or stop/reverse vaginal atrophy? Additionally, if it's a local treatment, will that affect potential bottom growth?
Oh, that's such a great question. So that's huge, right? Because a lot of the enjoyment and pleasure we get from life is that intimate sexual experience. And you finally become comfortable in your body, and then that part of your body that you maybe want to use doesn't work as well. And so a lot of times I'll recommend some topical estrogen cream, similarly to what a cis woman would use after menopause to prevent the same issue, because older people also like to be intimate. But instead of using it every day, like is often recommended in a postmenopausal woman, I'll recommend it maybe once or twice a week. And that's often enough to prevent that vaginal atrophy, to prevent that dryness, without causing a lot of those estrogen changes. Because it's a topical cream, it's not absorbed systemically, and so it should not raise your estrogen levels to the effect that it's going to interfere with that testosterone. And so I wouldn't expect to have less bottom growth just with that topical treatment.
Awesome. What is your experience or professional feeling about quote microdosing with HRT for non-binary people or genderqueer people?
I think as long as we're protecting the bones, then I think that microdosing is okay. What I will do in somebody who just wants a teeny bit of transition one way or the other, is I'll measure levels. I'll measure both the estrogen and the testosterone at every visit, making sure that we're keeping the levels such that we think the bones are being protected. But as long as you're getting a sex hormone for the bones, I think that it's fine.
Next person says, just wanted to thank you for what you do and for this presentation. That's the last question that's in there. I want to give everyone just a minute here to make sure that no one else has any lingering questions. I appreciated all these questions. Some of these were questions I had myself, so I'm glad that other people asked them. Everyone took my questions, which is sick. Because they're super important questions. See. Okay, does not look like anyone else has any questions. So I want to thank you, Dr. Folsom, for taking this time out tonight to, share your education with all of us and being willing to answer these questions. Oh, someone says also thank you. So another thank you. I think creating spaces like this is super important where providers can, connect directly with trans patients. Because it can be a bit scary going into a new appointment. That's one of the things we do through my program is like accompany people to their medical appointments and try to like make sure it's a good affirming experience for them. So I really appreciate you being here and being willing to connect with the community in this way. And hopefully folks got all their questions answered. And we recorded this, so it will be up on our website once I can add subtitles to the question bits. So yeah, thank you all so much. I hope that everyone has a great rest of their evening. Wait, Dr. Folsom, is there anything else you wanted to add?
Gosh, I'm so delighted to be able to meet with everybody tonight and to be a part of the journey of so many wonderful people. Truly, just meeting my patients and being a part of their lives is so rewarding to me. And I think that they all and you all have done so much more for me than I feel like I do for you. So it is an honor and a pleasure to be part of this community.
Wow. I can attest that the feeling is mutual. So I really appreciate you being here for this and showing up for our community. I hope that everyone has a lovely rest of your night. If you have any lingering questions, maybe email me, maybe email Dr. Folsom. Maybe we'll get it figured out. But I appreciate you all being here and connecting. And with that, I am going to end this webinar if I can. Maybe I should have figured that out beforehand. There we go. Bye, y'all.